There we go. For herself, and then we'll pass over to Vikram to deliver the session. We're expecting it to be about half an hour worth of content and then another half an hour, give or take, of interaction, questions and answers. So please do stick around. We are recording as well. So if there's anything that you don't want to share that would be made available on the website, just be mindful that this session is being recorded. If you want us to stop at any time, if you do particularly want to share something that's personal, then feel free. We're gonna respect that so that this can be as fruitful for people in the room as possible. So, Babita, handing over.
Thanks, Stuart. Well, welcome everybody, and thank you for taking out your time on a Wednesday evening as well to sit with us and meet with us. I'm really pleased to meet you all. Just a quick introduction, I won't say too much. So I'm Babita Paul of New Chapter Nutrition. I have a real interest in gut health and looking after menopausal women as they transition from perimenopause to menopause and even earlier, because I do feel that gut health is really important for hormones, whatever your age is. And I just love doing one-to-one transformations and trainings on health and optimizing your health by food and nutrition. So I'm looking forward to delivering the next 3 webinars. I don't profess to know everything about thalassaemia, but I'll certainly do my best in delivering some content that you would find helpful. One little thing to think about just before next week's session is have a think about what did Hippocrates say, the father of modern medicine, over 2,000 years ago, and we'll be exploring that over the next coming 3 weeks.
Great, thank you, Babita. And now, Dr. Vikram Talaulikar, over to you. If you don't mind doing a quick introduction as well for those who may not know you in the room. Thank you.
So thank you, Stuart, for the kind sort of start and introduction and for the invite to present today. Thank you, Babita. You're going to do most of the work in this series, which is going to be the next 3 sessions. I'm just giving the teaser today, but you're doing the most of the bulk of the work. And I think it's do no harm, right? The Hippocrates, if I let out the secret. So interesting what you're going to come
That's
up with.
one of them. I have 2 more really good ones as well.
Okay, good, good. I'm interested to know what they are, so I will be joining hopefully next time. So my name is Vikram. I do the menopause clinic, a sort of reproductive medicine clinic related to thalassaemia at UCLH. So as some of you or many of you might know, UCLH works with Macmillan Center. This is where hematology clinics happen, and that's where the thalassaemia clinic is. So my role in the clinic is really looking after women for their hormones, for their fertility in relation to thalassaemia. I've taken over from someone called Dr. Chatterjee, Dr. Ratna Chatterjee, who has been doing the clinic for a long while. And then she retired, so I took over the clinic. And that's really where my interest into this subject comes. I'm going to give you a little bit of introduction as to menopause in general. What are the specifics in relation to thalassaemia? Is menopause different in women who have thalassaemia? Are there some considerations which are unique to individuals with thalassaemia that we should be considering? When does it happen? Why does it happen? If someone has symptoms, how do we get around them? Can we use hormone replacement? Can we use non-HRT interventions? A little bit of each, because it would be too much to cover everything in detail in, say, 1 hour. But I'll leave you with some points or messages to think about. I'll really invite you to ask me your questions or share your experiences, because this is a niche area. Not many people before have talked about menopause in women with thalassaemia. So again, I'm grateful to Stuart, Red Cell Network, Babita for coming up with the menopause topic, particularly in relation to thalassaemia. So I'll share my slides now and hopefully talk for the next 20-30 minutes, go through the slides, and then we'll open for questions. Okay, so hopefully you will be able to see my slides now, and just shout Babita or Stuart if you can see them.
Yes, we can do.
Okay, so what's the background? Why are we talking about menopause in relation to thalassemia? Because we know there have been lots of advances in transfusion medicine, in ion chelation therapies over the years. And all that has meant is that women with thalassemia are living a better quality of life, are living longer. And as you come towards 40s and 50s, of course, the question of perimenopause and menopause is becoming relevant for more and more individuals with thalassemia. And the aim for us is, in terms of clinic or medical or clinical care, is that women who have perimenopause or menopause don't have a poor quality of life, they have a good quality of life, they don't suffer from symptoms. And at the same time, we want to care for their long-term health, their bones, their heart, their cognition, and metabolic health. So there are many reasons why focus on menopause and thalassemia has come into highlight. Now let's look at what are the general stages towards menopause, the journey towards natural menopause. And I'll talk specifically about thalassemia a little while later. So for any woman who is having her own hormones, having natural periods, the journey really starts with perimenopause. So before the age of generally 35, 40, 45, most individuals, most women will be having regular periods, monthly menstrual cycles. They will not be having any symptoms of lack of hormones. They will be having normal levels of estrogen, normal levels of FSH, LH hormones in their bodies. The first phase where menopause starts happening is called as the perimenopause. So perimenopause simply means it's a phase of fluctuation. So ovaries start making less and less of the hormones estrogen, progesterone, less of testosterone, and the hormones fluctuate. So it's not like it's an abrupt ending. It's up and down, increase and decrease in estrogen throughout the week, throughout the month, throughout the years. And the hormones fluctuate widely. So some days FSH and estrogen are normal, other days they are abnormal. And these fluctuations then give rise to abnormal periods. So there'll be irregularity of periods. Initially, the periods may be too frequent. Later on, the periods become spaced out. There are gaps in periods. Eventually, the periods will stop. And while this is happening, these fluctuations are happening, symptoms start happening. So there may be some hot flushes, some mood fluctuations, sleep disturbance. There may be vaginal dryness, bladder issues, lots of fatigue or joint pains and aches. All those sort of subtle symptoms may start showing up, but periods will continue, although irregular. That phase naturally for most women will be between 2 to 5 years, sometimes maybe longer, and for majority will be between 40 to 50 years of age. Then comes menopause. So menopause is diagnosed or someone is gone through menopause when they've stopped periods for 12 months. So once 1 year has passed and there have been no more periods, then we say somebody has gone through the menopause, and it's always a retrospective diagnosis. And finally, the post-menopause phase begins. So this is 1 year since the last period until the end of life. So this could be 5, 10, 20, 30, 40, 50 years of someone's life. So it's a long, long period of time. And this is when we want to make sure we preserve the quality of life and help with the long-term health. Now, some women may have slightly different experience, especially if they've had a medically induced or a surgically induced menopause. So some women may need operation to remove their ovaries. Let's say if there is a malignancy, there is cancer, there is cyst, there is tumor. They may have endometriosis. Some may need medical medications or medical treatments like chemotherapy, GnRH, many others, which can stop ovaries from functioning and induce a medical or a surgical menopause. That can be quite abrupt because you don't get the time that happens naturally for a gradual menopause to happen. It can be an abrupt form of menopause with lots of symptoms, persistent symptoms, and they need more attention, more monitoring, more support if that happens. Now, symptoms vary. So you can have an individual who may have very little symptoms. They go through menopause, they don't realize, they may have very little flushes, very little mood changes, and they are postmenopausal, don't suffer from poor quality of life. While you can have other extreme, where you can have lots of debilitating severe symptoms, severe flushes, severe joint pains. And that really does have a major impact on quality of life. Again, some women may only have symptoms for 6 months, 12 months, 1 year. Others might have it for 10, 15, or even 20 years. About 10% of women have it much longer. And so two individuals may have a completely different journey, although they may be same age, so they may have same medical history, same BMI. So it's individualization that's really important. When does menopause happen? In the Western world, in the Caucasian population, the average age of natural menopause is around 51. So the age range being 45 to 55, majority of women, 90%, will stop periods. For about 10%, it will happen between 40 to 45. And this is called as early menopause when it happens between 40 to 45. For about 1%, it will be below the age of 40, which is premature menopause, technically also called as premature ovarian insufficiency. And for 1 in 1,000, it will be as early as less than 30. So you could go through menopause in your 20s and 30s, 1 in 1,000, and that is very premature menopause. So it's important to know that even young women, for some reason, genetic, medical, immune, can have menopause very early in their life. So it should never be dismissed if they have symptoms. Ethnicity is important. So you look at the figures and you sometimes feel amazed, because if you look at Indian women, Southeast Asian women, they have 5 years earlier menopause than Caucasian women. So that's 5 years early. It's quite a big difference as compared to white population. If you look at Afro-Caribbean women, they have 1 to 2 years earlier menopause on an average. So you need even more care or input about bone health, brain health, heart health because of such early onset of menopause. So there is a lot of ethnic variation, and this is partly due to genes, but partly also the socioeconomic factors. Diagnosis of menopause is really based on symptoms. We don't really rely on blood tests. For natural menopause, it's all about symptoms. So if somebody has menopausal symptoms after the age of 45, you don't need any blood test to confirm you're in menopause. You can be offered HRT or any other intervention without having to do a single blood test. So that's really important, because there is a lot of unnecessary blood testing that happens. And so we don't want that. The only time we do blood tests is for somebody who has premature menopause, say under the age of 40, when we are thinking about fertility aspect, we want to confirm the diagnosis. That is when we'll look at FSH level. But otherwise, it is all based on symptoms and not blood tests. Now let's look at the specifics of menopause regarding thalassaemia. Now, for many women, we know that they will be on transfusion therapy, they may have iron loading, and that can lead to multiple organ effects, because the extra iron in the body is going to cause multiple organ effects, including endocrine or pituitary dysfunction. And that means that some of the women will stop having periods because the pituitary gland is no longer sending signals to the ovary. The FSH and the LH is very low because of damage to the pituitary by the excess iron. And that will mean that the ovaries don't produce estrogen right from an early age. In 20s, 30s, 40s, the ovaries will stop functioning. That's not menopause. That's secondary stopping of ovaries because the pituitary is not working. So the ovaries have eggs and they have the capacity to produce estrogen. That's different from menopause, but they're not doing it because the hypogonadotropic hypogonadism or the lack of pituitary signaling is not letting the ovaries produce the hormone. So these women are usually offered HRT right in the beginning from an early age in 20s, 30s, and 40s. So they will already be replacing hormones, but that's not for menopause HRT. That's for hypog or pituitary dysfunction. For them, as they come towards 50s, they will gradually transition into the menopause, but they will not know that they've transitioned from hypog, which is lack of pituitary signaling and lack of ovarian function, to lack of ovarian function because of the ovaries becoming older. So there'll be a transition from HRT for pituitary dysfunction to HRT for menopause. So they have to make a decision around 50, whether they would want to continue HRT for menopause rather than taking HRT for the pituitary dysfunction. For those who continue to have periods, continue to have natural menstrual function, they will have the same trajectory like many others, like the women without thalassemia. So they will keep having periods until their 40s, and then they will enter perimenopause. They will have irregular periods and symptoms, and eventually stop for 12 months, and they will enter menopause. Now, again, for women with thalassemia, you can have natural menopause at 45 and above, or they may have early menopause, 40, 45, or they could have premature menopause below the 40. So that remains same. The only one factor is if they've had hypog early on in life, they will already be on HRT, and so they may not know when they actually went from transition to menopause. Now, what are the symptoms of menopause? So menopause affects head to toe. All the tissues, organs in the body need estrogen hormone. And so there'll be lots of symptoms for some women and few for others. But it can start from the head. So headaches can be a symptom of perimenopause. Brain fog, not being able to concentrate or multitask, often memory starts failing. Low energy, fatigue can be another one. Hot flushes, night sweats, sleep problems, quality of sleep goes down. These are typically sort of classical symptoms. You can have dry skin, dry eyes, itching of the skin, joint pains can be other symptoms. You can have low mood, heightened anxiety, palpitation, which we typically call as the psychological symptoms when in perimenopause or menopause, women start experiencing low mood and depressive thoughts. Irregular periods will be a feature of perimenopause and then completely stop during menopause. And finally, there can be local symptoms. As the estrogen rise up, there can be vaginal dryness, painful intercourse, libido might drop, and there'll be less of sexual desire. All those are classical common symptoms of menopause. There are many others, up to 20 more, but we're going to focus on the main ones which are common. Besides the symptoms, the changes to hormones cause some other effects. So for example, in the body, as the estrogen becomes less and less, the unfavorable lipids, the bad cholesterol, LDL, starts going up. The body fat distribution changes. So around midlife, there will be fat distribution around the tummy, and that usually is again partly because of something we call as insulin resistance. So the body fat distribution will change. Insulin resistance becomes more as the age increases. Blood pressure may start going up. Changes to blood vessels will cause them to be a bit more tougher and harder, causing the blood pressure to be high. Bone turnover will increase, so the bone density can become less because there is higher bone loss more than the bone growth. And there'll be some also changes to coagulation and blood clotting. So there'll be clotting abnormalities which might become more common after 50. Now, for individuals with thalassemia, these are in addition to already existing background comorbidities. So women might already have diabetes, already have blood clotting issues, already have low bone mass and osteoporosis, osteopenia, and thyroid issues. These will be additional changes at menopause in addition to those comorbidities. So how can we manage the symptoms of menopause and what can be done to protect the long-term health? So this is a quick summary. And again, I could discuss each one of these for hours, but we're going to restrict to a quick summary and then hopefully explore more in the question answer session. The first thing is lifestyle optimization. It does help with some symptoms, and it's equally important for sort of long-term health. I'm not going to dwell a lot on this because actually Babita is going to go into much more details of all this. So I'm going to simply say lifestyle is key. Even if you take hormone replacement therapy, it's important that you watch your diet, healthy diet, regular physical activity, exercise, especially weight-bearing exercise like lifting weights that can help with bone and muscle. Sleep is important. Most of us don't get a good sleep because of maybe taking screens to bed or not having enough hours of sleep, and that has an impact on symptoms and brain fog. So sleep hygiene is really important. Vitamin D supplementation is usually recommended for everyone, especially thalassemia, menopause. There's more requirement for bone for vitamin D. Calcium-rich, protein-rich food, something that I'm sure Babita will talk about. And finally, stress management. So considering CBT, mindfulness, if work stress balance, that's important. So that's mainly around the lifestyle optimization, and it may help with some of the symptoms. More so, it's important for future health. What are the non-hormonal options which one can consider for symptom relief? So some women may choose not to consider hormone replacement or may have contraindication. For example, they may already have significant blood clots or breast cancer, and that means they can't have HRT. In that situation, often there are other non-hormonal medications which can be useful. So the common ones are you have citalopram, venlafaxine, sertraline. These are antidepressant medications which can be used for hot flushes, low mood, night sweats, and sleep. They do have some side effects such as dry mouth, constipation, dizziness. But for those women who want to avoid HRT, they can be very useful for symptoms. There are others like pregabalin, gabapentin, clonidine, again, mainly used for hot flushes and night sweats. Oxybutynin is a particular one, especially with bladder symptoms. So somebody has urgency of bladder, along with hot flushes, night sweat, oxybutynin is quite useful. There are some therapies like CBT, cognitive behavioral therapy, or hypnotherapy. These are sort of psychologically based therapies, which can again help with hot flushes, sleep, anxiety, and mood. Then there's a new class of drugs called NK3 receptor antagonist. So this is called fezolinetant. This got approved in the UK this year in January. It's mainly a medication for hot flushes and sleep and used as an oral tablet, 45 milligrams daily. This doesn't have any major side effects, but it's a new drug. So we'll have to see in future when it's available on the NHS, if we can use it widely for women with thalassemia. Vaginal lubricants, moisturizers can help, especially for vaginal dryness, painful sex. Genitourinary symptoms can improve with vaginal lubricants and moisturizers if someone doesn't want to use vaginal estrogen. Of course, there are other alternatives which I haven't talked about much. So these would be, for example, laser therapy for vaginal dryness, or yoga as form of exercise, acupuncture, herbal remedies. Now, many of these have variable evidence scientifically. Some scientific studies show no benefit from them. Other scientific studies show some benefit. So we often don't medically recommend them as therapies or medication, but individual women may wish to consider these therapies. There's not much scientific evidence for them. Now let's move on to HRT. So there's so much talk happening right now about HRT. In fact, day after tomorrow is World Menopause Day on the 18th of October. So it's a good time to be having these sessions. And the theme for this year is hormone replacement therapy, or HRT. So let's focus on what HRT is. HRT is replacing the hormones which are becoming less during menopause. So we replace estrogen, we replace progesterone, and those two are the main important key hormones of HRT. Some women, we also replace testosterone. It's off-license prescribing in the UK. It's not a licensed hormone product for women in the UK, but we give it mainly when there is very low sexual desire or persistent low libido. HRT can be local, which means vaginal estrogen, vaginal pessaries, so creams, gel, or ring, or it can be systemic, patches, gels, sprays, tablets. And systemic HRT, or estrogen replacement, remains the most effective medical treatment for vasomotor symptoms which affect the quality of life. So at the moment, head-to-head, HRT remains the most effective medical intervention if someone has troublesome or difficult menopause symptoms. There is a long history for HRT. It's one of the most controversial medications over the years. And most of the controversy started around year 2002, 2003. So 20 years ago, the big study from US, which is called WHI study, Women's Health Initiative study, which was a randomized trial, was published. And that study was comparing HRT to a placebo to see what are the long-term effects of HRT for improving health. The study came out with results which were quite negative for HRT and suggested that HRT can increase risk of breast cancer, increase risk of stroke, increase risk of heart disease. There was worldwide confusion, panic. People gave up HRT. Health professionals were less likely to prescribe HRT. But actually, over the years, over the last 15, 20 years, things have changed. So NICE, the National Institute for Clinical Excellence, basically looked at all that data, which was 20 years ago, and then the follow-up since then until now. They looked at more trials in the last 15, 20 years. And then they came up with their own guidelines, which suggested that some of those dangers had been exaggerated because the population where the studies were done were not representative of healthy women or women in their 50s starting HRT. So what NICE said was that HRT is not a danger to women. And actually, for majority of women, the benefits of HRT would outweigh the risk. So there would be benefits for quality of life as well as long-term health. So let's look at what are the benefits, what are the risks, and what are the hormones we use now. What is the modern form of HRT? So there are many HRT preparations, more than 40 in the UK. The ones that we prefer are something called body identical or natural plant-based preparations. So 17-beta estradiol is an estrogen that's found in patches, gels, spray, tablets. This is the one that we prefer in the NHS and in the private sector. The progesterone that we prefer is something called natural progesterone or a body identical progesterone. And the other form is called diprogesterone, which is body similar progesterone. Again, these two are much better tolerated than some of the older versions like norethisterone, Provera. So basically that means that the natural progesterone and the diprogesterone are much better, milder versions of hormones than those that were used 20 years ago. They cause less blood clotting. They are less impactful on the breast. So they're much more friendly to the body. Now, 10% of women can be very sensitive to progesterone hormone. As part of HRT, they may have bloating, they may have mood changes, they may not like the progesterone. So sometimes one has to be very careful when choosing the progesterone as part of HRT. What are the routes? We looked about that. So you can have oral tablets or capsules. You can have skin patches, gels, or spray of estrogen. You can get pellets or subcutaneous implants, which can be inserted under the skin every 4 months. You can have vaginal estrogen cream, pessary, gel, or ring. These are for vaginal use. And you can also have a Mirena, which is a progesterone intrauterine coil. A coil that can be fitted in the womb if somebody has very heavy periods, heavy bleeds on the HRT. Now, out of these hormones, estrogen is the most important. It does suppress the symptoms, improves the quality of life. It protects the bones, it protects the heart, especially if you start HRT early, below the age of 60. It protects the bones, heart, and metabolism. It has some minor side effects. So estrogen initially as part of HRT may cause a little bit of headaches, bit of breast pain, bit of nausea, can cause a bit of breakthrough bleeding. But generally, these are temporary. And over a few months, most of these side effects of HRT will go away. Estrogen alone is enough if someone has a hysterectomy. So if a woman has had her womb removed, she only needs estrogen. You don't need the progesterone unless there was history of endometriosis. And estrogen is recommended for quality of life, bones, heart, cognition. So anybody who has menopause below 45, early or premature menopause, they must take HRT or estrogen at least until 50 because they need hormones to catch up and maintain their long-term health. So until 50 is something that we strongly advise. After 50, they can choose whether they want to continue or come off. The other hormone that's combined with estrogen is the progesterone. So as I said, progesterone is a necessary hormone. It's not the one that addresses most of the symptoms, but this is mainly needed to protect the womb lining. So a woman can't take estrogen on its own unless she's had a hysterectomy. So you have to give progesterone in addition to protect the lining of the womb because estrogen on its own can make the lining thick. Now, progesterone has some side effects like bloating, mood changes, breast pain, PMS-like symptoms. But again, these are temporary. For most women, they will improve with time. And if they don't, then you can change the type of progesterone until the woman has less side effects. It can help with hot flushes. The natural progesterone helps with sleep. any breast cancer risk that comes from HRT is because of the progesterone component. So estrogen doesn't increase the risk much, or rather doesn't increase it. It's the progesterone in the HRT that is linked to the breast cancer risk. And finally, you have testosterone, which is the neglected hormone, we say, because it's not being talked about until now. Not everyone needs testosterone. Some women find that their sexual function, their libido drops significantly after menopause. They have persistent low libido. And in those situations, testosterone can help. It also helps with energy, muscle, and bone strength. But really, it's mainly used off license in UK for low libido. Who should not have HRT, and when should we be cautious about it? So women who have had breast cancer, especially estrogen-dependent cancers, any gynecological estrogen-dependent cancer, bleeding which has not been sorted out, thromboembolic disease, blood clotting, major blood clots in the past, or active liver disease with liver enzymes being very high. In those situations, one should avoid HRT, and it should be used with caution if there is family history of breast cancer, or there is family history of significant blood clotting, or there's complications with diabetes and blood clotting, or migraines with aura. One has to be careful with the type of HRT used and the dose used. When do you use a bleed or a bleed-free HRT? So cyclical HRT or a bleed HRT gives you once a month bleeding. This is mainly for women who are still going through perimenopause or have just been menopausal in the last 1 year. That's when we use a cyclical HRT and then transition to no bleed HRT. While somebody who's already been in menopause for a long time, has used HRT for more than 5 years perhaps, they can go straight to bleed-free HRT. They don't need to induce cyclical bleeds. Hopefully we'll come to this when we come to the question answer. What about vaginal estrogen? Vaginal estrogen creams, pessaries are very useful. They're very effective for vaginal dryness, painful sex, urinary frequency, incontinence. Urinary tract infections become less with the use of vaginal estrogen. They help the pelvic floor muscle, and you can use them as long as required in the maintenance dose. They do not absorb in the rest of the body. They're very safe. Even some women with breast cancer can use vaginal estrogen because they don't increase the risk of breast cancer. So finally, coming to what are the risks? So we looked at all the benefits of HRT. It helps with the bone, prevents osteoporosis. It helps with the heart, prevents blood cholesterol from going up. It helps with symptoms, quality of life, metabolism. So what's the problem? What are the risks that we need to balance against all these benefits? There are 4 risks that we talk about and try to minimize. So the first is risk of any stroke or thrombosis. Now, HRT per se, the risk of stroke or thrombosis is very low. It's less than pregnancy. It's less than contraceptive pill. It's a very, very low absolute risk. But nevertheless, if somebody takes an oral tablet of HRT, their risk can increase by about 4 to 5 in 1,000. So there's a slight increase in risk of blood clots. So we try to avoid that. If somebody has a risk factor for stroke or blood clotting, like splenectomy or previous thrombosis or diabetes, then we try to use non-oral route of HRT. So if you use the patch, gel, or spray, you don't have this increased risk of blood clotting, which is only applicable if you take a tablet form. Endometrial or womb cancer, as long as you're taking enough progesterone to balance the estrogen in your HRT, generally that cancels out the risk of endometrial or womb cancer. But if you don't take enough progesterone, you take more estrogen than is needed, that's when the problems can cause endometrial or womb lining thickening, and cancer can be a possibility. So it's really important to get the doses right. Breast cancer is a risk after the 50s. So somebody taking HRT until 50, because they've had early menopause, premature menopause, hypog, they don't have an increased risk of breast cancer with HRT until you get to 50. But after 50, any further use of HRT, there is a small increase in risk of breast cancer if you use estrogen progesterone HRT. And how much is that? It's about 0.5%. So it's 5 in 1,000 extra women who can get a diagnosis of breast cancer for 5 years use of HRT. So you can see the risk is very, very small. If the background risk is something like 13, 14% for every woman, it's about 0.5% extra risk. And if you compare it to other factors, like having 2 glasses of wine a day or high BMI, excess body weight, that has much more risk than the HRT. And finally, heart disease. Again, if you take HRT early, below the age of 60, it helps with heart function, helps with blood vessels, better cholesterol. So it helps with reducing heart disease in future. But if you start it late, say after 60, then those benefits won't be there. This is just a slide that shows you how much is the risk of breast cancer if you compare it to other lifestyle factors. So if you take 1,000 women, say between 50 to 60, and follow them up for 5 years, about 23 out of 1,000 will get a diagnosis of breast cancer. This is the background risk for any woman. If you look at HRT, there'll be extra 4 to 5 individuals in 1,000 over 5 years. So very small increase in risk. If you look at estrogen-only HRT for women who have had a hysterectomy, it's actually less risk of breast cancer. It doesn't increase at all. So for women who have the combined pill, it's exactly the same as HRT, same risk. For women who have 2 or more units of alcohol per day, the risk is bigger than HRT. For women who are smokers, similar to HRT, 3 in 1,000. And those who have BMI above 30, you can see huge increase in risk. This is the real risk for breast cancer, high BMI. Almost 24 extra women getting the risk of breast cancer. Exercise is always good. It reduces the risk by 7 less individuals. So exercise, weight-bearing exercise is excellent. Final slide. So duration of HRT. If someone starts HRT in their 40s and 50s and they're feeling better, they're getting quality of life better, they have protection for bone and heart, how long do they carry on? So there's no absolute one age where you can stop HRT. It's an individual choice. So you can start in perimenopause, menopause, and you can carry on. Is there an upper age limit? No. As long as benefits outweigh risk, women may choose to stay on HRT till 55, 60, 65, 70. It's individual. Most women will use it for 5 to 15 years between 50 to 65, and they eventually come off it. Then they do experience no longer symptoms, and then they will stop at some time. So usually it's 5 to 10 years for majority of women. Particularly in thalassemia, we haven't done well with research. There are no good papers that exist, no good studies that have been conducted about what is the best HRT for women with thalassemia, because there may be many complex issues involved, like splenectomy, like blood clotting risk, diabetes, osteoporosis. And we really will now be learning from now on as we do more and more studies, as we prescribe HRT to more women with thalassemia, we will learn more. So until 50, if you've had early stopping of ovarian activity or hypog, HRT has benefits but no risk. After 50, you have to balance the benefits against the risk of clotting and breast cancer. So with that, just a final message to say menopause should be viewed as an opportunity to make changes in your lifestyle, because as Babita will probably cover in the next 3 sessions, there are lots of changes happening in the background, and gut health or metabolic health becomes important. So exercise, diet, regular screening, stress relief become all important alongside whether you will have HRT or not. A lot has changed in the past 2 decades. Menopause experiences are unique to individuals. And so whether you consider lifestyle, non-HRT, HRT options, it's your choice. And it will always be discussed with you as part of menopause management. Remember that modern HRT is more body identical, safer. So if you decide to go on it, you can ask your GP, you can ask your specialist clinic to consider HRT for menopause symptoms. But it's important to make sure that the benefits outweigh the risk. So thank you very much for patiently listening. It's a bit of a whistle-stop tour, but I hope to expand on some of those points when we take your questions and share your experience. So thank you very much.
Brilliant. Thank you, Vikram. Very informative chat, and I hope it's been a benefit. I'm sure it will have been for everyone in the room. With the questions, like I said at the start, we can be accommodating with people if they don't want to talk. So if you'd rather put your question in the chat, I'll ask it directly. But otherwise, if anyone's got any burning questions to kick us off, then please, I suppose the best way to do it is to put up a hand, and we'll do them in order. So, who's the
I
brave?
don't have a question, but I found the talk very enlightening, very helpful, especially with the risks and the new modern information around HRT, which obviously can be
Thank you.
very
Thank you,
helpful to
Babita.
individuals. Yeah.
Any questions? Have you answered everything?
It was very concise.
We do have a question. So we've got one. The first one is, how do you know when to move from cyclical progesterone to a daily dose?
So the best way to do that is depends on how long you have been on HRT. So for anybody who is on cyclical HRT, getting a bleed every month, the choice to move on to a non-bleed HRT would be between 1 to 5 years. So if you've been on a cyclical version for 1 year or longer, you've got up to 5 years where you can make the change. And the only reason we suggest changing to a no bleed or a continuous progesterone HRT is because it then makes it less likely that you will get any polyps or endometrial womb lining thickening, which can happen the longer you stay on a cyclical HRT. So I would say any bit between 1 to 5 years would be a good time to move on to a bleed-free HRT.
Thank you. And we've got another couple. So, in the scenario of being on HRT for 2 years, and there has been no change to your symptoms, and your only symptoms to start with was anxiety and brain fog. I suppose, in that question, and please correct me if I'm wrong, the question is, would there be a need to change if there's been no change to those symptoms?
Yes, I think so. There are two situations here. Either your symptoms were not due to hormones or menopause to begin with. Anxiety, brain fog can also happen due to other reasons. It may not always be hormones. So in that situation, taking hormones won't make a change. But it could also be that actually you're taking hormones which are not being absorbed. All of us absorb different preparations differently. So some women will use patches and have no absorption of hormone into their blood. And we often discover that when we do a blood test to check absorption level. Similarly, some may take oral HRT and find it doesn't work, but the transdermal skin patches or gels work. We all are very different. So either you're not absorbing, and that's why the symptoms are carrying on, in which case it would be good to test blood level to make sure that you're getting the hormone. And if you're getting the right amount of hormone, then it's probably not hormones is not the answer. You may have to work on other aspects of managing anxiety and the brain fog.
Thank you. So a few coming in now. So what are the risks of taking testosterone for someone with thalassemia?
We don't know that. So the simple answer here, as I said before, is we don't know what are the risks of testosterone because not many women ever with thalassemia have been offered testosterone. We use it as part of menopause for women without any background medical conditions quite commonly. Generally, risks of testosterone are very minimal because it's used as a gel. It goes through the skin and the dose used is so little. It's almost 1/10 the dose of, say, used for men. And so that dose is unlikely to cause any harm. So one could use it in women with thalassemia. The higher doses are the ones that we don't like because they can cause a bit of hair growth, bit of acne, bit of oily skin or scalp hair loss. So never go down the high route or high dose route. As long as we stick to 5 milligrams or less of the dose of the testosterone as a gel, then generally you can get benefits without exposing yourself to any major risk. So you could consider it, but the data are very poor.
Thank you. if you have a history of fibroids, is HRT recommended?
You can take HRT with history of fibroids. Any hormones, whether it's estrogen, whether it's progesterone, will often cause fibroids to grow. But the growth is very small. So something like 5 millimeters or 1 centimeter a year. So if you've got fibroids which are less than 5 centimeters and you are starting HRT, the only recommended sort of intervention there would be have a scan, have a pelvic ultrasound to your GP at least once a year to know that your fibroids are not responding very fast to the HRT. Majority of women will stay on HRT for long and never have significant growth of fibroids. They'll carry on absolutely fine. In a minority, if the fibroids start growing fast, then you might have to deal with the fibroids first if you want to stay on HRT so that you don't get the pressure effects or bleeding because of the fibroids.
Thank you. So there are a few more, and I will get through each of them in chronological order. We just need to be mindful as well of time. So if anyone's got burning questions, please pop them in the chat now, because we'll maybe draw a line under new questions in about 5 minutes or so. On the next one, that this has been passed on to me, and there may be part of the question missing, so I'll do my best. If a person had had a hysterectomy and didn't have any hot, I'm assuming, flushes, and now that person is in their 50s and feel like they need something, I'm not sure what that's referring to. Can you start it this late? I'm assuming that's HRT.
You can have HRT late, especially if you've had a hysterectomy in the past, but let's say your ovaries were preserved, then you would still be having ovarian function. And later down the line, you can go through menopause once the ovaries stop and you become symptomatic. You can start HRT at that point. If you've had a hysterectomy, ovaries were removed at the time, you usually have symptoms straight at that point because the ovaries have been removed with the hysterectomy, in which case symptoms now would be unusual, most likely not linked to hormones. But if the ovaries were preserved at the time of hysterectomy, then you could have symptoms now. You can consider HRT. We don't have much medical information, so we're not giving individual advice here, but do see your GP and discuss with them so they can refer you to a specialist hormone clinic, because there are a lot of factors we'll have to take into consideration when we make a decision like that.
Great, thank you. And again, someone sharing an experience. They've been on HRT since the age of 18, as their periods never started owing to iron overload to the hormone glands. They're now 50, and they're asking what their options are. And I think there's a suggestion to lean the answer towards cyclical HRT.
Yeah. So this is a very common situation. A lot of women I see in my thalassaemia clinic also have been on HRT. They've been taking HRT because of the pituitary damage, because they wanted to preserve their bone health, their heart health. So they've been on HRT for a number of years until coming to 50. At this point, now you have a choice. You can gradually reduce your dose of HRT like a natural menopause would happen, less and less and less of your HRT preparation, and then eventually come off. So in 51, 52 age, you can come off completely. And if you don't have symptoms, you don't need HRT. Any sort of further protection to bones, heart, it's much better to do non-HRT rather than just relying on HRT. But if you have symptoms, if you try to come off at 50, 51, and if you have symptoms of menopause coming, this is different from the reason you took HRT before, then you can consider going back on HRT. But the only sort of additional factor here, as I said, is the breast cancer risk. This wasn't applicable to you until you got to 50. Now, if you extend it after 50, you have to weigh that all the benefits you're looking for symptoms, for bone, for heart, you have to balance that and know that it's against a small increased risk of breast cancer. A lot of women choose to continue till 55, 60. I'm seeing so many in my clinic who have continued, but it's an individual decision. As long as you feel the risk is small, then you can carry on with the HRT.
Thank you. And
of course, you can convert from cyclical to the bleed-free now because you don't want to be continuing to bleed after having HRT for so long. So you can certainly go continuous progesterone bleed-free HRT. Sorry, Stuart.
No, it's fine. Thank you. And I think you may have touched on this throughout, but there's a question around whether there's the option to just not take HRT and whether the doctors would be happy with that.
Yes, they should be. So remember that HRT is really a treatment for symptoms after the age of 50. So until 50, HRT was recommended if you did not have your periods because the pituitary wasn't functioning. It was protecting your bones, your heart, your brain, in addition to giving you symptom benefit. After 50, it changes. You don't have to necessarily take HRT. If you don't have symptoms in absence of hormones, like many women naturally going through menopause at 50, you can come off completely and you can simply follow bone and heart with other non-HRT intervention, whether it's statins, bisphosphonates. There are many other medications if needed. Good lifestyle, exercise, diet would be really critically important. There are non-HRT therapies which you can avail of. So you don't have to have HRT. It's just mainly for symptoms. If they're not going away with lifestyle or non-HRT intervention, then HRT will help again.
Thank you. So two questions, one after the other around testosterone, one around whether or not it will help with energy, and the other one, bone density.
So testosterone is, in terms of the energy, some women report when they go onto testosterone that they have increased energy. They see that their brain fog is less, they feel that their mood is better. But for many, this is short lasting, often tends to be a placebo effect. The main reason to prescribe testosterone where it really helps is the lack of sexual desire, low libido. Other effects like energy, brain fog, mood, they seem to be temporary. Some women continue to have them for maybe 6 months, 12 months, but there's not good evidence that they will last longer, which is why we don't recommend right now testosterone for those reasons. For bone, it's mainly estrogen and your weight-bearing exercise, diet, calcium, vitamin D, that's really the critical bit for bone. We don't recommend testosterone for bone yet.
Thank you. And I will need to draw that then with questions at the moment for new ones. If I can just make a correction because it's came through, the part of the question earlier that I thought was missing the word flushes, it was a mistypo of HRT. It came through as hot. So I'm not sure if that changes the answer, but I will come back to that one as the last question. So someone's asked if you could explain the treatment options for a patient who suffers with PMDD.
Yeah, so PMDD is a very difficult condition and often you're very sensitive to the progesterone. So PMDD is premenstrual dysphoric disorder. This is when in the second half of the menstrual cycle or the HRT preparation, the progesterone is not tolerated. And there are lots of symptoms, psychological or physical, bloating, mood changes, depression, irritability, breast pain, GI issues, digestive issues. All those can surface together, headaches, breast pain. They can all happen as part of the progesterone sensitivity. It's also thought that in a natural cycle, the dip in estrogen before the periods can also contribute to it. So for PMDD, we tend to choose different forms of progesterone and find out the one that you can tolerate. For example, some women may tolerate utrogestan, natural progesterone, well, and not have as many PMDD symptoms. So we try to do that. Others may tolerate a synthetic progesterone like Provera. Some may do well on a Mirena coil as a progesterone. Others can take Tibolone as a form of HRT, which is sort of non-natural hormone HRT. Still others sometimes have gone down the route of having actual hysterectomy, removal of ovaries if they're still having natural periods, and then only having estrogen as a HRT, because after hysterectomy, you don't need progesterone. But that's last option, that's extreme option. So there are many things you can do to try and avoid progesterone sensitivity. It's a challenging condition, but you usually find one HRT that works in that situation.
Thank you. Great. So there's 3 more questions. One more around testosterone, and what should they look out for if they do decide to go on to testosterone, which indicates that it's having an adverse effect on their body?
So look out for any excess hair growth on the body. So hair on the chin, hair on the chest, hair on the rest of the body will be an indication you're getting too much. Any oily skin, acne, or thinning of scalp hair, again, means there is more testosterone than you need. You can reduce the dose in that case. And those will be the main common ones as adverse effect. Extreme high levels of testosterone may cause changes to voice, but that we don't see that clinically because we use very little dose of testosterone. So unless you're getting these side effects, and your GP or your health professional will often do a blood test once a year to just make sure that your levels are within range. As long as those two are fine, then you're unlikely to get any side effects from testosterone.
Great, thank you. So two more. I'm going to go back to the classification or the clarification for the previous question first, and then we'll finish on something around brain fog. So the question's been clarified as follows. The person in question had a full hysterectomy. I think from memory this was in their 20s or late teens, but wasn't prescribed any HRT despite being symptomatic. They're now in their 50s and still suffering, but don't know what to do.
Gosh, that's probably not good care, I would say. But of course, we're talking about maybe 20, 30 years ago when maybe the hormone knowledge wasn't as same as now. Certainly, if you had hysterectomy and the ovaries were removed that many years ago, you should have been already on HRT until now. But if you haven't had it and you're still suffering from symptoms, you can either choose non-hormonal medication or you can still consider HRT for symptom. You should see your either GP or a specialist in the area so that we can go through the symptoms, decide your medical risks, and then you could have either HRT or non-HRT intervention. You'll certainly probably have an improved quality of life if you considered one or the other.
Thank you. And I misremembered. So there was no distinction given within the earlier question, whether it was that long ago, 30 years ago. But I'm sure the answer still applies. My final question, and the final question from the group tonight, is around brain fog. And generally, I suppose a reminder to everyone, what would you suggest helps the most with brain fog?
So if the brain fog is because of lack of hormones, perimenopause, menopause, lack of HRT, then generally hormones will improve your brain fog significantly. And a good form of HRT, making sure it absorbs well, will make a big difference. But sometimes, despite having good HRT and good blood levels of absorption, it may not go away. And that's when we suspect it may not just be the hormones. Brain fog can simply happen because of, let's say, bad sleep hygiene, can happen due to anemia, fatigue, can happen due to some vitamin deficiencies, part of thyroid insufficiency. Some medications may be causing brain fog and impact on brain. So there are many other life and work factors which may contribute to brain fog. So certainly one of the things you can do is consider HRT, especially if it looks around the hormones, perimenopause, menopause. Make sure you're getting enough through the HRT, and that should clear the brain fog. If it's not, then you have to look for other causes and non-hormonal interventions.
Excellent, thank you. And I'm sure everyone on the call will join me in showing my gratitude for you being on the call tonight, Vikram, and answering all of those questions. I think having direct access like this to someone with such expertise in the area is really invaluable. So massive thank you.
Pleasure.
From the perspective of the next few sessions in the series, like we laid out at the start, although I recognize not everyone was on the call, we will be doing the next 3 sessions over the next 3 Wednesdays. Please do spread the word. It will be Babita leading those sessions, and it will take a slightly less clinical route. And maybe a bit more interactive throughout. So please come ready to chat, ready to share experiences. And I will be there as well next week. I won't be there for the final 2, but we'll hope to run it in a similar fashion. So please try and be as close to on time as possible. we'll be collecting feedback as well at the end of the series, and for that feedback to be informative and to make sure we keep delivering useful things for the thalassemia patient group, we need you to attend these. So please do continue to come along for the next few weeks. I promise you they will be beneficial. Again, lastly, huge thank you to Vikram. We'll stop the recording. This session will be made available on the Red Cell Network website. I will send that link out to everyone who's signed up. And if there's anyone that signs up